So, as you know, I will be talking to you of advances in neuroradiology in brain metastases. The role of imaging in brain metastases is not just limited to screening and diagnosing, but also in the treatment and following and monitoring the treatment effects. We know that the incidence has increased because of various factors, including aging population, improved systemic disease control, and the use of sensitive imaging techniques. Most of the patients with brain metastases do present with signs and symptoms. And in the acute setting, CT is very important because it can allow for rapid detection of neurosurgical emergencies. And in addition to that, see if the tumor has acute hemorrhage or if it has calcification and any other invasion into the osseous structures. However, the gold standard is MRI, and we now have very conventional sequences. In addition to that, you have some extra and advanced sequences. The conventional imaging, you have the pre-contrast T1 weighted sequence. This is very important because you do want to make sure that there is no intrinsic T1 hyperintensity in the lesion that you're trying to see has contrast enhancement. This intrinsic T1 hyperintensity can happen because of subacute hemorrhage. The post-contrast imaging workhorse is the 3D FSP-GR sequence. This is a volumetric sequence. It is usually acquired in the axial plane, and thereafter you have reconstruction in the sagittal and coronal planes. There is another sequence called the 3D fast spin echo, or the FSC sequence, which also is a very good sequence. However, there is a bit of penalty of time, and we know that when patients are in the scanner for a long time, they move, and that sort of makes the whole study less valuable. What is the value of FSC? It is basically what we call the black blood technique. In this, the vessels are black, or the blood is black, not enhancing as you see in the FSP-GR. And so you could say that you would not mistake a blood vessel for a small metastasis or vice versa. The other conventional sequence, which we are all familiar with, is the T2 weighted imaging, which along with fluid suppression allows for easy detection and evaluation of the edema, which is accompanied by these brain metastases. As we are all aware, brain metastases can either be intraaxial or extraaxial. The intraaxial lesions can either be parenchymal or leptomeningeal. You have already seen with Dr. Servio the parenchymal lesions that she operates on to decrease the mass effect and patients having a better outcome. Here is a smaller lesion than what she has shown, and this is a solid single lesion that you can have. Single lesions are not terribly common, but they are not uncommon either. You can see it from up to 25 to 45% of tumors that metastasize. In comparison to this single lesion, which is although small, but still you're able to see, here you have little dots, which are truly metastases and are treated with gamma knife radiation. Leptomeningeal metastases, you have heard about the management and the various trials by Dr. O'Brien. And while sometimes it can be very florid, I've chosen this case to highlight that you can have it at the lower end of the cerebellum along the fovea, and in that case, sometimes you're helped by flare, which shows you hyperintensity. One must always hone on not along the fovea and the cerebral sulci, but also along the internal auditory canals or the course of other cranial nerves. The next case is a little bit more subtle because here, this is an FSE case, but this is not a 3D, it is 2D, and you can see you have vessels and they can confound detection of these areas which are leptomeningeal disease. One of the ways to know that is these follow the morphology or the direction of the folia. In addition, one must pay attention to the thickness of the nerves. Here is a trigeminal nerve, and you may not think that there is terribly lot of enhancement, but there is a bit of undulation and nodularity and enhancement asymmetrically more on the right than on the left. The same patient has the sagittal reconstructed images, and this is from the axial image that I had mentioned to you before, the volumetric images, and you can see linear enhancement along the ventral aspect of the brainstem, and you can also see it in the interpeduncular fossa. While speaking about the 3D imaging, I must highlight that you have one chance to get it. What that means is if your source images have any motion or any sort of artifact, it will carry over onto your sagittal and coronal reconstructions, and that could be a bit confounding. Dural metastases. These are not very common, but when they occur, it is mostly from breast, prostate, and lung. Also, for dural metastases, typically, it is not an unknown primary cancer. They do know that the patient has a primary cancer and has manifested somewhere, and thereafter it metastasizes to the dura. You can see here that the lesion is extraaxial, it is broad-based, it is indenting the underlying brain parenchyma, and there is another focus here in the posterior fossa. Sometimes you can have lesions which are dural based, which can be a bit confounding because they go into or seem to be aggressively entering into the underlying brain parenchyma. And in these cases, you will have basically flare hyperintensity, which denotes edema resulting in mass effect. As far as additional sequences are concerned, a lot of us are familiar with susceptibility-weighted imaging, diffusion-weighted imaging, perfusion, and MR spectroscopy. So briefly, to highlight what is the importance of it. Susceptibility-weighted imaging is a gradient-weighted imaging, which basically gives signal because of paramagnetic properties. The first thing is, how do you make out that it is a susceptibility-weighted imaging other than looking at the header? And that is because you will see a big hole because of the air in the nose and also along the bones. This is a case of melanoma where you see the patient has had hemorrhage, and this is a hemorrhagic lesion being visualized as a decreased signal on GRE star sequence. Diffusion-weighted imaging we are all familiar with because of its applications in stroke, and it's related to basically measuring or assessing what is the Brownian motion of the water molecules. In cases when there is increased cellularity or increased protein, also you can have restricted diffusion, as in cases of cell swelling, which occurs with stroke. So the water molecules cannot happily move inside the cell, and that is the reason you get a high signal on the diffusion map. But you must always check the ADC map to make sure that you have a corresponding dark signal. And the reason for this is because the diffusion map is really simplistically saying an amalgam of both the ADC and T2 shine through. And T2 shine through can arise because of quite a bit of edema or also because of encephalomalacia. What is the point of doing, or what is the value of diffusion-weighted imaging in brain metastases? Well, you come in here and you have this patient who has presented with left arm weakness and is new to the ER. You see there is a ring enhancing lesion within the right frontal lobe with surrounding edema without any significant mass effect. On the corresponding diffusion map, you see there is a hyperintense signal in the rim corresponding to the enhancement. Now, you must go back to the ADC and you can see that there is a thin rim of hypointensity, which is basically because of the cellularity of the tumor. But in the center necrotic area, there is no restricted diffusion. As you all know, that when you have a ring enhancing lesion in the brain and the patient is presenting with symptoms, you can always have an abscess, which has to be the differential diagnosis. In cases of an abscess, which is this case from the literature, you can have a ring enhancing lesion, but in contradistinction to what I showed you earlier, here it is the purulent proteinaceous stuff in the center, which is bright and dark on diffusion and ADC map respectively. Regarding perfusion imaging, this is because there is increased blood flow to the tumors and you can have various metrics. The common ones are the dynamic susceptibility contrast, or DSC, which measures the relative cerebral blood volume. It is relative because it is a ratio to the mirror or contralateral area, which is normal, and therefore you will be able to see whether it is abnormal or normal. Arterial spin labeling measures the cerebral blood flow. That means the flow of blood per unit, per gram, or per amount of tissue. The advantage of this is you do not have to give any exogenous contrast, but it does have a very low signal to noise ratio. There are ongoing improvements and hopefully this will see the light of day soon. Dynamic contrast enhancement, or DCE, measures the permeability or the leakiness of the vessels. While this has its value in gliomas, it is not as robust as DSC because of the inherent issues with getting an absolute value of K-trans. And that is beyond the scope of this lecture, but definitely for a physics person to look into. What is the use of DSC? So we do know that you have increased blood supplies. This is a case from the literature of somebody with cancer who presented with symptoms and had histologically proven brain metastases. The A panel is a T2 imaging without the suppression of fluid, and you can see that there is flare hyperintense, there is T2 hyperintensity surrounding the lesion, which is heterogeneous in nature with the hypointensity reflective of the increased cellularity. The middle image is the post-contrast image demonstrating enhancement, and the last one is the RCBV DSC, which shows that you have corresponding increase in blood supply, because the ones which don't have blood supply are very blue and sad looking. MR spectroscopy is good. It finds what is the biochemical profile of the tissue that you're interrogating. The common metabolites you are aware also are NAA, which basically is a measure of neuronal viability. It is at 2 parts per million, as you can see on this lovely graph. It is an old graph from publication in Brazil, but it was just so clean looking. I could not resist putting it in here. The creatine is what tells you about normal cell metabolism, and choline is what tells you about the cell membrane turnover. So when you have abnormality, as in case of tumor, your neuronal viability is down, so NAA decreases, the normal cell metabolism is sort of like an internal control. If people have done basic sciences, it is like beta-actin when you're doing PCR. And choline is when you have cell membrane turnover. So if the cell is dying or getting changed fast, it will increase. The normal, you see this upward acute angle, which is called the Hunter's angle, where choline is a little less than the creatine and Na is the most. In terms when you have tumor, everything goes haywire. So Na falls, creatine sort of remains approximately the same or less, because it is really, as I said, an internal control, and choline increases. And that's why you always get asked for the choline to creatine ratio, because these values on the y-axis can vary from scanner to scanner and from vendor to vendor. So MR spectroscopy, while very nice, it is tedious, and also it takes a long time, and it's not very much used. So what is its value in brain metastases? That is, once again, when you have a single lesion and it is large and you do not know if it is a glioblastoma or if it is a single brain met. In that case, you will basically interrogate the areas of the tumor, around the tumor, and a contralateral side to see what is the changes. Here is examples very nicely published in the literature from the Greek group. And this is somebody who basically had lung cancer with a large heterogeneous appearing lesion, as you can see, within the left occipital lobe. The first panel is the one which shows the intratumoral interrogation of the metabolites. And now you can see that the angle has reversed, with choline being rather high and creatinine low and Na much low. You have your comparison to the it was integrated right about here. You will see that the peritumoral area is similar to the normal brain parenchyma. This, in comparison to somebody with glioblastoma, as you can see here, the intratumoral is similar. Now you do have lipid and lactate because of the necrosis, but in the peritumoral area, it has a similar pattern as in the intratumoral. That means the choline is high, the NAA is decreased, maybe not as much as the primary tumor, because you can see in the contralateral part that there is a little bit more of the NAA. The next bit is about treatment. You have already heard the value in pre-surgical planning and in surgical and stereotactic treatments. Monitoring treatment effects can be to see whether you have true progression or pseudo progression, and also for surveillance. Now, true progression is easy when all the lesions you have treated have gone, and then there are some new ones. But it's not always that simple. You can either have new lesions, which I said was very easy, not very, but relatively, if they're not too small. Then you can have a treated lesion, which shows some new enhancement, and then you have a treated lesion, which is sort of decreasing in size, but now has erupted again. This is an example of a colorectal cancer who presented with progressive left arm weakness. The first panel, you can see there is a ring-enhancing lesion and there is edema. The patient received gamma knife on 11/25/21, and the follow-up, which should be 22, so apologies for that, is the patient did get smaller, the lesion did get smaller, but then on the follow-up scan, it increased. What is this? We did not know, but because the patient was having symptoms, they put him on chemotherapy, or I think Avastin is what it was. So the follow-up imaging, this time he was still increasing. This is during Avastin, and then suddenly you have a larger lesion and you have a little excrescence over here. Could this be radiation? necrosis, yes, absolutely. But what is odd is that with Avastin, enhancement does decrease. So when you do see new enhancement in the context of patient getting Avastin, you must be very suspect. Also, this sort of outpouching, which is very focal, is atypical for radiation necrosis. You may have more finger-like or a little bit more undulating sort of margin, but in my experience, this focal sort of nodularity with a little bit of necrosis is atypical for radiation necrosis. So this patient, based on imaging, was taken to the OR, and sure enough, this was recurrent metastases. Here is a case with breast cancer, and the patient had received whole brain radiation on 4/30/2021. I see I have the years right now. So the pre-treatment scan, you see you have a couple of lesions in the posterior fossa, the largest one on the right, heterogeneously enhancing. Post whole brain radiation, this has decreased, as have the others on the contralateral cerebellum. Then this lesion starts to become a little bit more angry looking, and there is increased enhancement and irregularity, which persists through 10/22/21. The patient is also having symptoms. Now, what is this? Could it be radiation necrosis, or could it be recurrent tumor? Now, sometimes you may get a hint that this is radiation necrosis. As you can see here, you have these little streaks coming through, possibly, but one cannot be sure. So this is when you have perfusion imaging that can come into play, especially if the patient is not a surgical candidate. Here is a little bit of a grainy lesion, which is the same image actually as the previous one, and you can see that the lesion is again heterogeneously enhancing, and on this, which is basically the DSC, the relative cerebral blood volume, there is no red. Hello?
Más blandito, menos cuello, porque te le va a huear la...
Oh, hello, can you hear me? You basically have no increased perfusion, or just very little. And on ASL, once again, red is hot. It is not very hot here. So this turned out to be radiation necrosis, and the patient was followed up. Regarding additional advanced imaging other than MRI, you have PET, and what it usually is used for is to differentiate tumor recurrence from XRT changes. You can have PET, which is FTG avid, or non-FTG PET avid. The non-FTG PET PET imaging is really with amino acid tracers and is still experimental. The FTG PET is not typically used to distinguish primary from neoplasm from metastasis in the brain, but can serve to basically help in determining if you have recurrence or radiation.
Parece que perdimos a la doctora.
Hello, can you hear me?
Ahí viene.
Yes, okay.
Okay.
I wasn't sure.
There. Thank you.
Okay, so what is next? We all know that artificial intelligence is taking root in all aspects of life. And it obviously has started having some sort of influence on radiology. In terms of brain metastases, do I think it has a role? Absolutely. But I do not think it will be replacing radiologists, because you will still
Dr.
need
Guha,
to have.
we don't see your slides, just an FYI.
Oh dear, I apologize. Did it just go? Can you see it now?
Thank you. Yes, in slide mode,
Yes.
maybe you can switch to presentation.
Yes, I am just going to go. Sorry, when did I stop showing slides? I think my internet connection.
Yeah, it is
Did you
just
see
now.
this? Yes. Okay, so basically that's what I had to tell about advanced imaging, and what I was saying was what's next, and it is AI, which is infiltrating all aspects of life. And I do believe it has a role. It will be helpful, but I don't think it will be able to do without oversight and without an user interface where you need a radiologist for varying reasons, including being able to distinguish small mets from artifacts. Also, you have other confounding factors such as hemorrhage, or if you have a RAP artifact. So while it is I'm looking forward to it because it means that I don't have to count all those metastases, but I still think we are a bit far away for routine use. Well, thank you all for your attention. And once again, thank you for the opportunity to speak at